All right, we are going to start talking about terminology on page 11 of the ultrasound. So, on page 173 in the 5th edition, they have, under ultrasound definition, they have a brief sentence that includes almost all the terminology you need to know, which I think is kind of funny that they put it all in one sentence. But basically, in brief, ultrasound is a high-frequency sound wave that can be described by its intensity, frequency, duty cycle, effective radiating area, or ERA, and beam non-uniformity ratio, or BNR. It enters the body and is attenuated in tissue by the absorption, reflection, and refraction. And absorption counts for about 1/2 of attenuation. Attenuation is tissue and frequency specific. It increases with the collagen content of tissues, meaning the collagen is absorbing a lot of the energy, and it increases with the frequency of the ultrasound. So we're going to talk about all of those things. So when we talk about intensity, power or intensity, power is an energy per unit time, and it's expressed in watts. So when we talk about the intensity of ultrasound, it's the rate at which energy is delivered. So it's power per unit area of the sound head. So we express that in ultrasound as watts per centimeter squared. So the range of intensity for therapeutic ultrasound is 0.1 watts per centimeter squared to 3.0 watts per centimeter squared. So we want to use, as with everything, we talked about this a little bit in the pharmacology section of pathology last quarter, but with everything, with exercise, with modalities, with medications, we want to use the lowest effective dosage. So the lowest intensity that is going to get us the result that we want. So when we're doing a thermal treatment, when we're applying the ultrasound to heat tissues, the initial treatment parameters are set according to theoretical and research predictions, but we use the patient's report of warmth to determine the final ultrasound intensity. So we might start at, let's say, just for example, 1.4 watts per centimeter squared, but then we're going to get some feedback from the patient on whether or not they feel warmth. So for a thermal application, the lowest effective dosage is the lowest dosage at which the patient feels warmth. Okay, if that makes sense. So when we talk about the intensity, in the one slide way back here, there it is, it looks like a big solid beam that's all going out at the same intensity. And of course that's a drawing. And you can't really see ultrasound. But in reality, it's a more jaggedy, like this drawing. So we talk about the average of the intensity across the transducer head. It tends to be, the peak tends to be where the intensity is greatest, and it's usually at the center of the beam, and it's lowest at the edges. So it's sort of like a jaggedy bell curve looked at in cross-section from here, or like a mountain when you think of it in 3D, the peak intensity being the peak of the mountain. So the peak intensity is where the intensity is the greatest, so that's one of the reasons why we want to move the transducer head around, so that peak intensity is not just at one spot, we're moving it around. So the average is the average intensity across the whole sound head. And the non-uniformity ratio, or BNR, beam non-uniformity ratio, is the ratio of the peak to the average. So when you have a technician come in and service your ultrasound equipment, they are looking for the beam non-uniformity ratio because we don't want the peak to be too high from the average, because you could actually cause burns with it. So 6:1 peak to average ratio and lower are acceptable values when the ultrasound is being tested. And of course that is not something that we do, but it's something that's done by a technician that services ultrasound machines. So if you work in an outpatient clinic, you probably have a private company that comes in and does your servicing. I work in an outpatient-based a hospital-based outpatient clinic, and we have a group of technicians that work at the hospital that they call the biomed group, and they service all the equipment in the hospital. So continuous ultrasound is generally used to produce thermal effects, and continuous ultrasound is just like it sounds. The ultrasound beam is on the whole time. So this graph, very not too interesting graph, but the intensity stays the same the whole time. So pulsed ultrasound is used for non-thermal effects. So the beam is on for a certain amount of time and off for a certain amount of time, and it's usually measured in milliseconds, which is a thousandth of a second. So with a 20% duty cycle, it's on for 2 milliseconds, it's off for 8 milliseconds. So out of 10 milliseconds, it's on for 2, off for 8. If it were a 50% duty cycle, it would be on for 5, off for 5. So the off part of it is what allows the heat to dissipate so heat doesn't build up. But both thermal and non-thermal effects of ultrasound can be used to accelerate your progress towards your treatment goals when ultrasound is applied to the appropriate condition at the appropriate time. So, of course, when you have thermal ultrasound, you're also getting the non-thermal effects. When you're doing continuous ultrasounds, you're getting both. With pulse ultrasound, you just subtract the thermal effects. So frequency, as we've talked about, is the number of compression rarefaction cycles per second, and hertz are cycles per second. So at 3 megahertz, which is the higher intensity on the ultrasound machines that we use in the clinic, it's a more superficial effect, 1 to 2 centimeter depth. At 1 megahertz, it's a deeper effect, 3 to 5 centimeters. So when we talked about the relationship of tissues and how deep things are, increased frequency causes increased tissue friction, and the absorption of energy is greater, and therefore it decreases the depth of penetration. So if you're working on something like a hand or a foot that doesn't have very deep tissues, you're probably going to be using that higher megahertz setting for a more superficial effect. If you're working on other tissues that are deeper, quadriceps or hamstrings or low back, you are probably going to go for the deeper effect at the 1 megahertz. So this is the little graphic from the book that compares the two. 1 megahertz is deeper, 2 to 5 centimeters. 3.3 megahertz is more shallow, 1 to 2 centimeters. The effective radiating area of the transducer face is the area of the transducer that radiates the ultrasound energy. The ERA, effective radiating area, is always going to be smaller than the area of the transducer face. And that's because of the non-uniform vibration of the crystal. So there's always going to be a little edge on the transducer face that is not radiating any ultrasound energy. The part that is the effective radiating area. So near field, it's a convergent zone that is due to interference in the beam causing variation in the ultrasound intensity. So it's dependent on ultrasound frequency and the effective radiating area of the transducer. So most therapeutic ultrasound is absorbed within the first 2 to 5 centimeters, which lies in the near field. Okay? And we're not going to worry about the X0 max. So the sound waves that enter the body are attenuated by 3 things. Absorption, which is the conversion of mechanical energy of ultrasound into heat. So the higher tissue density collagen tissues with a higher frequency of ultrasound equal greater absorption. Okay? Reflection is a redirection of an incident beam away from the surface, and it goes at an equal and opposite angle to the beam. So that's why we use a transmission medium, either gel or water, to reduce reflection. If you just put the ultrasound head on someone, it would reflect right off their skin. So we need that transmission medium in order for it to be absorbed into the tissues. The other thing that attenuates ultrasound is refraction, which is sort of the bending of the ultrasound wave. And you see that in water with light. you have the light wave coming in, and the light wave is distorted when it hits the water. That's refraction. The same thing happens with ultrasound when it's going through biological tissues and water. So here's our little diagram. The incident wave is the ultrasound coming in. The tissue interface, if we don't have that a transmission medium, a lot of it's going to get reflected. What's transmitted is what goes straight down from the incident wave, and what's refracted is the direction change that results from the hitting of the different tissue structures that are in there. So all of those things, absorption, reflection, and refraction, contribute to attenuation, which is the diminishing of the intensity of the beam. So the attenuation is actually the rate of ultrasound intensity loss, and it depends on absorption, which is the greatest influence. The energy is absorbed by the tissues, reflection and refraction. So the higher tissue density, that is more collagen, and the higher frequency, you get greater attenuation. That's why the high frequency beam doesn't go in as deep, because you get greater attenuation. So this is a table from the book that has the attenuation of 1 megahertz ultrasound, and you can see that bone absorbs the most, and blood absorbs the least, and skin, tendon, cartilage, those things are in between. So skin and tendon and collagen, or especially tendon and cartilage, because those have a lot of collagen, they tend to be on the higher end. Bone is the highest, and then the muscle and blood vessels and nerves and everything tend to be on the lower end. So the parameters for ultrasound that I want you to know are intensity, which is measured in watts per centimeter squared. That's the one you see all the time because you chart it all the time, every time you do ultrasound. The frequency is in megahertz. You chart that all the time as well. The duty cycle is in percent, so it's going to be 20%, 50%. Some units have a 10% cycle, but it's usually 20 and 50. Or 100 for continuous ultrasound. The effective radiating area, or the ERA, and it's in centimeters squared. That's how much of the transducer head is radiating the ultrasound energy. And the beam non-uniformity ratio, and that is the ratio between the spatial peak and the spatial average intensity.